Hi, Dr. Paulomi.
Good evening.
Bhimsen.
Yes, sir.
Bhim?
Paulomi.
Yeah, good evening. Good evening.
Yeah. Good evening, ma'am.
Good evening.
Will you, Dr. Paulomi?
I'm fine. I'm fine. It's been a long time, I think.
Yeah. Real long.
Yeah, I had some confusion today. I thought it was 8. And
It's okay. It's okay.
But I have
We have behaviorally managed it, saying that it's a technical issue.
I know, but I'm ready. I can just present slides because I take this class regularly for residents. For many years, I've been doing the learning theory applications for the MD residents at Enhance. So I will just move from one section to another. It's okay, and we can discuss as we go along. That's not a problem. I think we can have case-based discussion.
Okay.
I think they've started, I think.
Okay, Bhimsen, you can start.
Yes, sir. Vishwas, please start.
Okay. Good evening, everyone.
Recording in progress.
Good evening, everyone. I'm Dr. Exposurebased here, and I welcome all of the delegates and participants, and to this webinar series on psychotherapy primer. Today, Dr. Paulomi Sudhir, she is going to talk about the behavioral therapies in psychiatry, and I just give it to our. I welcome all the. I welcome Dr. Paulomi. I welcome our Dr. Somshekar sir, his secretary, and I welcome Dr. Abhay Matkar sir, today's chairperson, and I will welcome Dr. Vincent sir, who is also the coordinary, one of the coordinary, and I welcome all the students and any other mental health professionals who are watching this thing. And I give it to the Dr. Somshekar sir for any opening remarks.
Okay. Thank you, Vishwas. Good evening to one and all. On behalf of Indian Psychiatric Society Karnataka chapter, it's my pleasure to continue this series on psychotherapy primer. IPSKC is doing this activities, webinar activities, academic activities for the benefit of the postgraduate students and the practicing psychiatrists and many mental health professionals. in various fields. Last year we did sessions on neurology, neurophysiology, then psychopharmacology, and many more subjects. This year we started the psychotherapy primer. This is the third session which is going on. So I definitely am sure that this will benefit the postgraduates as well as the other practicing mental health professionals. So on behalf of Indian Psychiatric Society, I welcome the today's chair, Dr. Abhay Matkar, who is our past president of the Indian Psychiatric Society, Karnataka. Welcome, sir. And also I welcome Dr. Paulami Madam, who is my teacher, who will be there speaking on the behavioral therapy methodologies and all those. So welcome, Madam. And I also welcome today's the host, coordinators, Dr. Bhimsen and Dr. Vishwas Adbad. Also the sponsors of the program, Mr. Arun from the Icon Laboratories, and all the participants who have joined here and also who have joined on the YouTube channels. Definitely, this will be one of the best program what you will be learning from regarding the behavioral units. So we have experienced that listening to the madam many times. So definitely postgraduate students will get benefited. Over to Dr. Bhimsen.
Thank you, sir. I request our chairpersons for today's session, Dr. Abhay Matkar. Sir is professor and head of Department of Psychiatry, SDM. I request sir to take over and introduce our speaker for today's session and go ahead with the scientific session.
Okay. Thank you, IPS KC, for giving me this opportunity to chair an important session by one of the most learned speakers of our country as far as this particular topic of CBT is concerned, and more so with the behavioral therapy is concerned. I have listened to Dr. Paulami on many of occasions. I've attended her programs as such, and I am extremely happy that I have been chosen to be the chairperson of such an important assignment or a program by IPS KC. I have the proud privilege of introducing the speaker also as of now. Dr. Paulami has completed her MPhil in 95 and PhD in 98. She is currently the professor at the Department of Clinical Psychology at NIMHANS, and her main area of interest has been behavioral medicine in NIMHANS. There is a specialized unit in NIMHANS that provides psychotherapy services, more so on stress and lifestyle clinic at NIMHANS Center for Well-being. Her areas of clinical research and interest include cognitive behavioral therapies, mindfulness-based interventions across psychological and medical conditions, psychological processes in health and health behaviors. She has mentored more than 20 MPhil and 15 doctoral scholars, in addition to contributing to research projects that she is associated with. She has published over 60 research papers in national and international journals in her areas of interest and 7 book chapters. Dr. Paulami has conducted several workshops for mental health professionals as well as other professionals in CBT and on stress management and workplace well-being. She is a member of professional bodies including IACP, IPS, and the American Psychological Association. She has been a member of IACP Task Force for Guidelines for Psychotherapy Supervision. Over to Dr. Paulami.
Thank you. I think I can share my slides. Before that, at the outset, I'd like to thank IPS Karnataka chapter for inviting me here. I hope I'll do justice to the introduction and to the topic, because although I've been teaching this very routinely, I understand the applications to a resident is very important. We do have residents who are posted with us, and I think the learning of behavior therapy techniques is the foundation for many other psychotherapeutic approaches, including the third wave therapies, and it forms a fundamental basis. I will take you through some of the theoretical aspects and then keep that minimal and then go on to the actual techniques. What I would probably appreciate is lots of questions and to pause or ask about any clinical cases that you would like to discuss. Otherwise, it becomes like a reading out a chapter or mostly theoretical. So I would appreciate if the audience can raise questions also. Let me just begin by, please let me know if it's visible.
Yes, madam.
It's
Kindly make your full screen.
Is it full screen now?
Yes, madam.
Okay. So thank you. And I think without basic theoretical aspects, it becomes difficult. So I'll quickly run through some of the definitions. I promise not to read every line of the slide, which probably will take a long time. What I'd like to emphasize when we're talking about behavior therapy, understand we had a session already on cognitive behavior therapy by Dr. Sudhir Hebbar some time ago. So what we need to understand is that the two are actually connected in a lot of ways, because we're looking at what does learning actually mean when we do therapy. And behavior therapy is therefore a family of therapies that we see, which consists of many techniques that are broadly related to the field of learning. So when we have clients referred to us for, let's say, for obsessive compulsive disorder, for management of anxiety, for, let's say, social anxiety or panic, we're basically using techniques that are together based on the field of learning. But what we expect therapeutically is the change that we see in the person, and this change is brought about by an interaction with the environment. The change that we see as a result of this learning is also something that will occur rather relatively permanently, and we also see that it is enduring because practice is an important aspect of learning. So what behavior therapy essentially emphasizes is on a change in performance, practice, the knowledge or behavior that changes due to experience, and this is a rather continuous change. Now, most of the definitions of behavior therapy rest on the assumption that behavior is neutral, and when we formulate a case for therapy under behavior therapy or learning principles, we assume that we don't use good behavior or bad behavior, rather adaptive or maladaptive behavior is used, because most behavior is subject to the same laws of learning, whether it is a reassurance seeking that is continuous reinforcement or an appropriate behavior, learning remains the same based on the same principles. A very quick look at what were the factors that led to behavior therapy, and we're all familiar with the extensive history psychodynamic psychotherapy had. But there are three continents that are largely involved in the growth of behavior therapy, and these are also pioneers in including developing the construct of the idea of behavior therapy, in contributing to learning principle-based interventions, and of course, many interventions that are still applicable. So Joseph Wolpe, we all know, he's known for his work on systematic desensitization as a therapeutic procedure. Skinner from the US, who contributed and continues to be relevant in the School of Applied Behavioral Analysis and Operant Conditioning. I will talk about some of the techniques as we go along. And Eisen's work, particularly in the application of modern learning theory to treatment of behavioral and emotional disorders. So these are three major contributors, and their work primarily came at a time when psychodynamic work was very, very prominent. The World War had just gotten over. There were a lot of people with PTSD, and treatments had to be very exact and short and time limited also. So this is basically as a result of the growing dissatisfaction that psychodynamic therapy had, particularly in the length of treatment. And most of it was laboratory-based learning. So what are the basic assumptions of behavior therapy? I've mentioned a couple of them. I'd just like to say that when we take a history, when we do a behavioral analysis, which is very essential, we tend to focus on the behavior itself rather than a presumed cause, because what we cannot see or observe or patient cannot report or be reported by significant others may become difficult for us to identify and change. The trait theory to some extent is discarded. However, together, when we talk about personality traits or enduring personality patterns, it doesn't completely discard it, but does look at how these are also manifested in terms of emotions and behaviors. The psychological principles and learning are particularly the focus. So even when we formulate, we try and use and try and understand what is the learning history of the individual. And most of these techniques are, although developed in laboratory settings, have had several clinical or anecdotal examples, and the focus is on here and now. So we may not find many studies on systematic desensitization and so on, but we know their efficacy is there. And of course, more recently, newer methods of habit reversal and so on are coming up again in a big way. So the common features, I will want to talk about the specific methods and the learning theories, but the common features across behavior therapies, whether it is exposure response prevention, systematic desensitization, or behavior modification methods, have a few common features. One is that contemporary determinants that are assessed in the functional or the behavioral analysis. Overt behavior is important, however, it does not exclude currently also when a patient says, I'm feeling sad, the manifestations of withdrawn behavior, these are important. It must specify techniques which are spelled out very clearly in the rationale for treatment. Measurement and treatment of behaviors have to be specific and precise, whether it is a rating scale, whether it is visual analog, or whether it is a subjective report of change, but measured on a scale by the patient. And replicability is very important. If I'm doing relaxation and I train somebody or somebody is using it on a patient separately, the instructions and methods cannot differ from one therapist to another. Of course, therapist variables, therapist factors may differ because how I do ERP may be different from another person, but the structure remains the same, and therefore replicability has been proved across procedures. So before we go on to actually looking at understanding these therapeutic procedures, it's helpful to understand the various behavior therapy approaches in a certain way. One is we could understand it from a learning theory paradigm. So there are many interventions based on the classical conditioning paradigm. There are interventions based primarily on the operant or the reinforcement paradigm, and the social learning paradigm, we know from modeling, social learning, and social cognitive interventions are based on what Bandura provided from the social learning perspective. So these are important factors that we need to understand, and I'll take you very quickly through the basis. Otherwise, the techniques by themselves are not they're not relevant unless we look at the learning theory basis. So this is a formula. I will not trouble you with it, but basically we need to understand that a formula for all the applications are basically how we understand what is the stimulus, what kind of a response are we understanding, what is the consequence, and what is the relationship which is primarily given, when is the reinforcement given, and so on. And I will take you through some of this in a maybe simpler and more practical way. Briefly to look at the pioneers in the three learning theory models. Of course, we are all familiar with classical conditioning, but from the human response or the human psychopathology, the point of view of classical conditioning is that, of course, Pavlov discovered his work through experiments with the dog. We all know that. And just quickly go through this. What is important here, using the classical conditioning, I think the example of post-traumatic stress or phobia is very helpful to understand here. Of course, for the dog, it was a behavior that did not, response that did not require any learning. So salivation was a response that was reflexive, and the SR, the stimulus, which was the food, provided the salivation. Now, if you take a human example of phobia or a trauma experience, the autonomic nervous system and the processes involved in the autonomic nervous system do not require any prior learning, so it is fairly reflexive. And when it gets paired with cues, for example, the place in which the assault occurred or the place in which the humiliating experience occurred, those cues acquire a similar property. So we have the conditioned stimulus, which we largely know in various exposure methods as cues related to the fear experience itself. So to summarize, we have the unconditioned stimulus, which is the actual experience of, let's say, being stuck in a lift, or touching something that is very disgusting, and that is something that does not require prior learning. It produces a disgust or a fear response, which again does not require any learning. But when it is paired over various trials with other neutral stimuli, it also acquires the same property, which is now what we know as the conditioned response. So any similar situation can then evoke the same kind of emotional response. Now, what is important in the classical understanding of psychopathology, which is useful for us to apply in our learning theory-based work, is that the conditioned response in patients are very different from what Pavlov's dog did or what happened in very primary responses, which are drive-based. So here we know human responses, the conditioned response in phobias or in obsessions and compulsions, when we know there is anticipatory anxiety, the emotional aspects are very important. Also, many cues have a predictive value. So a single trial, for example, in a traumatic experience, one need not have multiple experiences of trauma. A single trial is sufficient as long as we know this vehicle or this sound is going to produce or lead to something that is very threatening. It is sufficient to produce a strong response from the individual. The other thing that is very important in learning theory-based applications is the concepts of extinction, which is what we hope will occur when there is a repeated presentation, which we know happens in exposure methods. There is a decline in the strength of this response, and I get habituated and I feel less and less anxious or fearful over a period of time. However, we also know that there is a spontaneous recovery. That is, you've done exposure with the patient goes back home, and there is a return of the fear or the return of the symptoms. In learning theory, we know it as spontaneous recovery because in a very short while, many patients will report they have gotten back their problems and the same patterns have got re-established. So, relapse can be understood as a spontaneous recovery also. So the classical conditioning essentially is very useful in understanding the development of fear and anxiety disorders, largely what we know from the emotional disorders perspective. Of course, there have been many criticisms against the classical conditioning over the years because it's not a simple form of learning that can be applied to complex behavior, and many people may not have had a classical conditioning experience themselves. For example, if I see somebody else being punished or going through a traumatic experience, I need not experience it, but I might develop anxiety responses to similar situations. So the other major contributor from the operant conditioning, we all again know Skinner from his work on the laws of reinforcement and the consequences. The difference is that there is a contingent nature of the response is followed by a consequence, and this finally determines how likely it is that the response will occur. So if it is followed by an aversive experience, then we expect a decrease. Otherwise, we expect a strengthening of this response. A lot of the behavior modification principles are based on the operant conditioning principle. Very quickly, key terms, of course, are the reinforcement, which is a key construct. Even more important is that it is contingent, it is not a simultaneous application. When we withdraw something that is positive, it also becomes punishing. And when we apply something like a rebuke or a memorandum served or a warning is given, that becomes a punishment. But when you withdraw privileges, it also becomes negative for the person and reduces the frequency of behavior. Like with classical conditioning, operant also talks about extinction, and this is very critically used in exposure and response prevention, where there is a continuous presentation. When you do prolonged exposure without any escape or avoidance, which is what we expect in ERP, there is a stopping of reinforcement. We expect extinction to occur. Now, contingent punishment is used in many of the childhood conditions. We know that following a certain behavior, let's say in contingency contracting and so on, punishment can also be used. So main concepts include the superstitious reinforcement, which we know as magical thinking in obsessive compulsive disorder, response shaping, which we use very often for training in social skills, and condition reinforcers, which we use in token economy. Token economy is not used very often now, But of course, in children's star charts or programs that are based on learned reinforcers can be used. So I'll come back to this when we talk about behavior modification principles. What I'd just like to emphasize is that it's not just the delivery of reinforcement, but also how one delivers these reinforcements. And I'll talk about problems that can occur when the reinforcements are either inconsistent or they are not in appropriate magnitude. For example, the inappropriate behaviors are reinforced with negative attention by a family member, or the reinforcement is given by reassurance seeking of a patient. Sometimes inappropriate, inconsistent patterns of reinforcement actually maintain problematic behaviors. So what is the difference between the two? We have mentioned the kind of learning. One is very reflexive, one is voluntary, one is requiring specific responses by the individual and is modified by reinforcement. Now, in the operant learning, we also know that when somebody wants to avoid, there is active avoidance. That is an example of an operant condition. Now, an important thing to understand is that both by themselves, classic and operant, do not explain all of the behaviors, because human behavior is much more complex than we see in laboratory animal models, but they form a good basis to understand some of the habits that are developed. Now, there's a lot of recent work on, let's say, trichotillomania, body-focused repetitive behaviors. Many of the OC spectrum behaviors that are maintained purely because they are reinforcing in themselves. So, some of the earlier learning theories are coming back into practice. Quickly taking you through some of the models which have led to interventions. One is, of course, counter conditioning, which is linked in systematic desensitization. And I'll talk about ST very specifically also. The third component or the third learning school, which is very important from the point of view of social skills, a lot of behaviors which are used in the social cognitive interventions that we see now was initiated by Albert Bandura. He's the pioneer of vicarious learning. And vicarious learning has bridged the gap between what we know as the SR theories and the cognitive foundations, because Bandura talked about language as being very important. Something that is imitated now or learned now is produced or practiced at a later point in time, because the person is able to remember, retain this information and use it at a later point of time. So language, what we know as cognition or imagery, is an important construct that we introduce as important in learning through observation or by vicarious means. So what is the importance of social learning theory when we talk about behavior therapy in schools of behavior therapies? We know that modeling is a very important strategy which we use in social skills, which we may use in rehabilitation settings, or even chronic mental health conditions where modeling for social skills is important. Of course, Bandura talked about several prerequisites that are important for learning to occur, particularly in being able to pay attention, to remember, to reproduce feedback, and to be reinforced by the behavior. Why I'm emphasizing this is also because when we know a client has, let's say, neurocognitive deficits or difficulties in learning, both acquisition as well as new learning can be a problem. And the informational transfer that we see in the acquisition of fears or expectancies and beliefs are also important part of the social learning theory. Now, self-efficacy, I'm sure when we did cognitive behavior therapy, we know that the beliefs about oneself or in one's ability is important, and that's again a major contribution from the social learning theory perspective. So, Morer's theory I'll talk about when I do exposure and response prevention. I will go on perhaps to summing up what these learning theories are and then go into the particular techniques themselves. I've mentioned a few of them. When we explain a model, a psychopathology model, we usually look at learning theories to explain acquisition and maintenance. This is true even when we use to explain obsessive compulsive disorders, many phobias, or anxiety disorders where the acquisition and maintenance is plausibly explained through these conditioning models. the most comprehensive of them being the social learning model. But whenever you use it in your clinical setting to formulate, it is better to use the combination of more than one, because human behaviors, like I've been mentioning, is not something that can be explained by a single approach or a single learning model. So I will talk about the techniques. I'm not sure if I'll have time to do all of it, but I'll vary the slides and see if I can cover the major intervention strategies so we keep time for discussion. I'd just like to request Vishwas to tell me when I should stop, giving me 5-10 minutes or more for the discussion also.
Okay.
So before we start, you're all used to taking the clinical case histories, right? When we do, when a patient comes to us for the presentation with the problem or treatment, we all take a case history. And the case history, the function of a case history is basically an algorithm that leads us to a clinical diagnosis. And then etiology and models and treatment approaches are logically based on that. However, when we are identifying therapeutic approaches, we use what is known as a functional analysis or a behavioral analysis, which leads to a functional diagnosis, more like a dimensional approach to understand what are the factors that are currently maintaining problematic behaviors. So we use the Cantor and Saslow's model, which has various sections that talk about the description of behavior, right up to what are the family factors that are maintaining it, and how are these actually preventing the person from bringing about change, including social expectations. Now, assessment and analysis is a continuous process in therapy. So at various points, we use it to identify if the patient is responding, if there has been a new problem that has developed, there has been substitute compulsions, and so on, so that we can bring about change. So using this approach, one can identify targets, plan therapy, and monitor progress. We substantiate this with all the rating scales, what you typically use like BIBOX, social anxiety measures, or Hamilton's, which will substantiate the information. So that's why we can use a variety of methods, triangulate them, and then use them to formulate for therapy. So for example, product of behaviors is useful, let's say when you're using trichotillomania or treatments with habit reversal, asking them how many hairs did you pull out. Can you produce a sample for a patient who says, I don't know how much I kept pulling today and I don't know how much it was. You can ask them to collect and show you the product so that you can keep that as a measure of change. And self-monitoring is also very essential in most of the conditions. We will talk about how that is happening. So I will start with techniques based on classical conditioning. I won't be able to do a demonstration, but then we are all familiar that at the basis of all classical conditioning methods are those that activate the parasympathetic nervous system. And so the progressive muscle relaxation is perhaps one of the most widely used methods. There are other ways of arousal reduction also. It can also be used to inhibit anxiety responses, such as that we use in systematic desensitization. Basically, it counter conditions the anxiety response. Now, there are various techniques that are based on classical conditioning. I've talked about relaxation. Likewise, even graded exposure or graduated exposure, which does not have escape or avoidance, because the person is only being exposed to cues, let's say, of getting into a lift and coming out, or climbing stairs. For example, if someone has phobia of heights, the exposure is only to those conditioned stimulus without any escape or avoidance and no relaxation method. But it is still based on graduated exposure and systematic desensitization, which is again based on counter conditioning. So essential for the overall arousal reduction is the relaxation response. And for all relaxation strategies, the aims are threefold: to reduce arousal, to increase thresholds for anxiety arousing cues so that smaller and smaller cues don't produce heightened arousal, and the time taken to reach baseline is also important. So if all these are met, then you know that the strategy is working. Otherwise, you may have to review and use a different method or see if the person is suitable or not. So the progressive muscle relaxation is perhaps the most widely used, but we also have a portable method which is known as the applied relaxation, which is preferred when a muscle tension or arousal symptoms all come together. For example, if there's an interview that I have to attend, and only at that time I'm experiencing anxiety, I can't do the whole JPMR. I have to do something that is very quick and takes a short period of time. So basically it's something that is based on progressive muscle relaxation, but the time taken, like these steps that I've mentioned, it has about 7 steps, each of which can be practiced over a weekly period of time, and finally the patient applies it in different situations. For example, just before an exam or an interview, I quickly review, see where the tension is, and I apply the relaxation or the release on. So for that, training in the progressive muscle relaxation is important. Blood relaxation has been widely used in generalized anxiety, in social anxiety disorders, but produces the same kind of relaxation in a very short period of time. So another classical conditioning based methods, I've summarized all of it in one slide. It may take many more sessions when you actually do counter conditioning. Just to give you an overview of what are the methods. We don't use systematic desensitization very often now because it's very time consuming. So preferred method is graduated exposure, which is more effective. However, sometimes when there is so much avoidance, or even when a person thinks about something, the anxiety is so high, it is useful to plan systematic desensitization, which is done in 3 steps. Very systematic training in relaxation, construction of a hierarchy, which is either based on time, for example, exam-based anxiety, or spatial. Then there is a distance, physical distance. You create a theme-based hierarchy, and then expose the patient to the anxiety-provoking cue while the patient is relaxing. So this is where the pairing is occurring rather than one after the other. That's why it is a classical conditioning method. The problem, of course, is when the person has skill deficits. We do not recommend using SD because the actual problem should be handled by the skills training. Somebody who has a fear of driving and hasn't really learned well enough, doing SD will not be necessary. It should be practice with driving that is more important. So what we talked about initially, for example, systematic desensitization, relaxation, are all anxiety reduction methods. Now within classical conditioning, we also have anxiety induction methods, and I think the most popular amongst them is exposure and response prevention, which is based on the 2-factor theory that one is acquired through classical, but it's the compulsions and the neutralizing behaviors that actually maintain the problematic behaviors in a continuity. So what happens in the exposure-based therapies? The aim, of course, is repeated presentation of the cue, and the cue, all of the exposure-based methods work on the principles of habituation. So no relaxation to be done while the person is doing the exposure, no compulsions, no escape or no avoidance is to be facilitated at any point, no distraction also. The hierarchy is built based on the cues given by the patient, so very systematic analysis is to be carried out. Imaginal cues may also be used, but the hierarchy is built in such a way that exposure is carried on at least with 50% reduction in anxiety for each cue. So I'll come to some of these steps, which these techniques may be more important. So many of these anxiety-inducing methods, we need to understand that self-directed versus therapist-assisted methods may be both recommended depending on how well the patient understands these approaches also. Now, from the ERP method, the ERP is possibly one of the most popular methods amongst the behavior therapy approaches. Of course, now we have cognitive models that are combined with the pure exposure and response prevention model. So what is the treatment outline for ERP? We focus on the change in the understanding of the obsessions. The person has to be explained the role of neutralizing behaviors and what is maintained through reinforcement. For example, if a patient is using safety behaviors that I don't sit anywhere because wherever I sit I might be contaminated, the role of neutralizing behaviors need not only be compulsions, it could be avoidance, safety behaviors, reassurance seeking, getting somebody else to check the logs because I may not be able to do a good job. All of these are included in the education to the patient. and enabling the habituation through obsessive thoughts rather than trying to get rid of the obsessive thoughts. The focus is on experiential avoidance that is distressing to the patient. And through exposure and response prevention, what is also important is the change in the faulty appraisals that if I don't tap 3 times, something bad will happen. The exposure will also provide for cognitive change in these appraisals. So these are broadly the components when we use educate the patient through the model. I'm talking about a cognitive behavioral model, but basically this includes ERP also, because before you do ERP, if you don't educate, there is a lot of problem with the adherence to the techniques themselves later on. So I will skip this because I think Dr. Sudhir may have talked about the cognitive model of obsessive compulsive behavior and DOC thoughts. So these are the major methods. Now, when we do ERP, I think it's important to also understand that therapist qualities are very essential, particularly because when we use exposure, clients who are not well aware might use subtle avoidance or substitute compulsion. So you'll see a sudden decrease in anxiety. Patient will say, I'm fine now, we can stop the exposure session, because there are substitute compulsions or the patient has said it's only a therapeutic session and so on. So it's important to be alert to that, and please give sufficient time for sessions, because about 90 minutes longer, sometimes it takes for a person to reduce even to 50% of what they've been experiencing. Now, when we talk about techniques that are based on operant principles, we are talking about basically the operations of reinforcement, punishment, extinction, shaping, and discrimination. So a variety of behavior modification and social learning theories are based on these behaviors, and you're looking at positive reinforcement, prompts, particularly in children when you're using skills training. Contingency contracting is used in adolescents, a lot of adults also where they're using eating behaviors and so on, and shaping particularly in children as well. Now, the definitions of reward, reinforcements, and so on become important when we understand what is the relationship between. I just summarized it in a table. Now, the confusion often happens between a negative reinforcement. So, any reinforcement increases probability of a response and also rewards, and any punishment should by nature decrease the probability of valence of a response. So, be very clear when you're using what is happening to that behavior. Is it expectedly reducing or has it inadvertently increased also? So sometimes when we talk about negative attention parents give to an inappropriate behavior in a public place, it is being accidentally reinforced, and the increase in behavior is what we see. So punishment should always lead to a decrease both in the attraction of a behavior as well as in the probability. So when you select reinforcement practice, we always choose appropriate reinforcers, arrange these contingencies appropriately, that is immediately after the behavior or intermittently, and therefore there should be a reliable response that occurs as a result of these reinforcers. So I've summarized again the types of reinforcers. We can come back to it if there are questions. But basically, reinforcers are not one broad category. There are subcategories within them. And even as individuals on a day-to-day basis, we operate on a lot of reinforcers, particularly like social reinforcers, or even generalized like credit cards, tokens, and so on. And these are particularly used in maintaining long chains of behavior, because when there's no immediate primary reinforcement, people can actually use it in even therapeutic procedures like dialectic behavioral therapy, for example, uses a lot of reinforcement principles as part of structuring therapy. These are the broad ways in which we understand it. However, when we're using it in interventions, we prefer to use social reinforcers because it is important in shaping, guiding our behaviors in everyday actions. And when social reinforcements are internalized, they also help in validating our own behaviors and preventing when there's loss of reinforcement and depressive responses. Social reinforcements become very important. So to make a reinforcement paradigm effective, we need to keep in mind the timing of the delivery, whether the person has already got the reinforcement, so you're providing it is not going to help. What is the size, amount, and type? So sometimes we find in families there are inconsistent, reinforcements provided. A small behavior is given a very large, reward, and this becomes a difficult pattern to unlearn, as well as availability and whether there are any biases in the reinforcement. So we presume that all children like chocolate or elderly people should like certain things, but always better to check what exactly is seen as reinforcer by the individual. So operant principles have a very wide range of application, not just in clinical settings, but also in workplace, educational settings, and very often in non-clinical settings, you find that it has a very vast application. So token economy is another one. I won't go into details only because one, it's a complex system and we don't use it very often unless you are using it in a setting where you want to establish several behaviors altogether. For example, adaptive and maladaptive behaviors together you want to establish is actually set up an economy where people can earn privileges by earning tokens, and the backup reinforcers will be going out for a movie or engaging in some other sport activity. These become the reinforcers which they exchange using the tokens. So the understanding of schedules of reinforcement is basically one sentence, that it is a relationship between delivery of a reinforcement and the response that occurs, either in terms of time or in terms of number of responses. A simple example is the variable schedule, which we know from gambling, for example. Gambling is a very good example of variable ratio where we don't know when the person is getting the reward. However, the person engages in very, very consistent behaviors. It's also very resistant to extinction. So from the application point of view, behavior therapy, we don't really plan interventions exactly based on variable or fixed ratio schedules. But when you look at school settings, or you have a child with, let's say, extreme inattention difficulty sitting, you could use fixed interval or you could use fixed ratio based on what you establish as a target. So in behavior modification, schedules of reinforcement become very, very important and relevant. So punishment is another problem in the ethical use of punishment, and but punishment is a very integral part of operant models. But the only problem is punishment has difficulties associated with rigidity, because it tells us what not to do, but it often doesn't tell us what we can do to earn positive reinforcement. So when you take clinical history of patients who have had fairly punitive parenting, a lot of parental psychopathology which has been influential in their socializing, you will find that they have difficulty in flexible ways of behaving, also because punishment has led to a lot of fear in responding flexibly. Also, negative modeling, that is, when I understand that punishment, I can also use force or I can also use violence, which is modeled by the parents and significant others. So some of the behavior modification principles based on punishment are the timeout and response cost. Timeout is not only used in children, but largely used with younger patients. But timeout can also be very relevant when we talk about timeout for behaviors such as